Good afternoon and a very warm welcome to all our viewers to today's special Hindi webinar on the occasion of World Glaucoma Day. Glaucoma is a set of eye diseases that destroys the optic nerve that can potentially lead to vision loss. Getting a comprehensive dilated eye exam can help in detecting the presence of glaucoma. One of the most common symptoms of glaucoma is slow vision loss. In angle closure glaucoma, people may experience symptoms such as sudden vision disturbances and nausea. Glaucoma, if detected in the early stages, can be prevented, and thus it is important to create awareness about the early detection of this eye disease to prevent further vision loss. Every year, World Glaucoma Day is observed with the intention of making people more aware of the set of diseases and the dangers of avoiding detection. As we gear up to observe this special and important day today, we have with us today distinguished ophthalmologist Professor Dr. Gursatinder Singh, presently Professor and Head of Department of Ophthalmology at Adesh Medical College and Hospital, Haryana. Dr. Singh is a distinguished ophthalmologist with more than 38 years of experience in glaucoma and neuro-ophthalmology. Dr. Singh has had extensive teaching experience and has published more than 15 articles in peer-reviewed journals. He is also the medical superintendent at Adesh Medical College and Hospital at Kurukshetra. Dr. Singh is an active member of the North Zone Ophthalmological Society. Welcome, sir. To chair the session today, we have with us today another reputed clinician, Dr. Rakesh Gupta, President and Director of the renowned Public Health Institute, Sipher. Dr. Rakesh Gupta is an eminent ophthalmologist with about 4 decades of experience. He has over 10 years of experience in managing and contributing to national non-communicable disease programs, especially blindness and tobacco control programs. Dr. Gupta represented India's Ministry of Health and Family Welfare for WHO consultations on e-cigarettes and plain packaging in 2016 and 2017, respectively. He actively attends international workshops and conferences, particularly on tobacco control and substance abuse. Dr. Gupta has received various awards, including the WHO Award on One No Tobacco Day in 2015 and the Award of Honor from the Punjab Red Cross for his contribution as a Chief Coordinator for Pan-India COVID Telehealth Line in 2021. It's a pleasure to have you both with us today. I would request Dr. Gupta to please open the session and welcome Dr. Gursatinder Singh. Over to you, sir.
Okay, hello everyone. So we are celebrating World Glaucoma Day today, and we have with us Professor Dr. Gursatinder Singh. He is Professor Head Department of Ophthalmology at Adesh Medical College and Hospital, Haryana, and he is Medical Superintendent 2 of the hospital. So we'll be understanding glaucoma from an expert, since Professor Dr. Gursatinder is a Fellow of Glaucoma from Aravind Eye Hospital. So this year's theme, Uniting for a Glaucoma-Free World, it focuses on bringing communities worldwide to fight together against glaucoma blindness, become involved and be a part of the activities organized over the globe. Help us raise awareness worldwide and learn more about glaucoma. We need to spread awareness and understanding about the importance of early detection of glaucoma, the world's second leading cause of blindness. So as I told you that Professor Dr. Gursatinder Singh, so he is the MD Ophthalmology from Govt Medical College, Patiala, and he is a fellow in glaucoma from Aravind Eye Hospital, Madurai. He has done a short-term training in medical retina in PJ Chandigarh, and the positions held in societies are various. He has been a president-elect North Zone Ophthalmological Society. He is member managing committee All India Ophthalmological Society. He is a nodal officer, multidisciplinary research unit of ICMR. And his academic achievements, research and publications are, he has been involved in framing guidelines on glaucoma by the Glaucoma Society of India 2021. His contribution towards publication of All India Ophthalmological Society and Glaucoma Society of India. So GSI Glaucoma Guidelines 2022, Guidelines for Glaucoma Investigation AIUS, Primary Open Angle Glaucoma Guidelines AIUS, Primary Angle Closure Disease AIUS, Glaucoma Diagnosis and Clinical Pathways AIUS. And he has delivered 96 invited guest lectures in various conferences and CMEs and has shared 41 sessions. He has presented 50 papers and posters at various international, national, regional conferences, and he has got 23 publications to his credit. So welcome, Dr. Gursatinder, and you may present your slides, please. Thank you.
Hello, everyone. So we are here to celebrate the World Glaucoma Day on 12th March 2024. As we all know that we are celebrating the World Glaucoma Week all over the world from March 10th to 16th, 2024. And the theme for this World Glaucoma Week is Uniting for a Glaucoma-Free World. We all know that glaucoma is a problem which has more than, it's one of the leading causes of blindness in the world. And during this world, the idea is to inform the public and disseminate the knowledge about the glaucoma and increase the awareness of glaucoma in the general public. And during this week, various activities are carried out, like you have Walk for the Glaucoma, different thematic activities, lectures, seminars are being done. So today's our endeavor is in the same string of the activities that we are doing today. We all know that 76 million people suffer from glaucoma worldwide in 2020, and 7.7 million have moderate to severe visual impairment. And this number is expected to rise to 95.4 million in 2030. If you look at the situation in our backyard, you see that 11.2 million people 50 years or older are affected, which is a significant number in that earning population. And every 8th individual, or nearly 40 million aged 20 years of older, are affected. And 10.2% to 12% total blindness in India is due to glaucoma. 90% of glaucoma is undiagnosed in India, unfortunately, because of maybe lack of resources, lack of knowledge, lack of expert people, and as compared to the 50% only in the developed countries. We all know what is glaucoma. Glaucoma is a condition in which there is a raised intraocular pressure, and there is an optic neuropathy. As you can see there is a large cup disc ratio, and there are visual field defects. So these all three constitute glaucoma. So it's optic neuropathy with characteristic appearance of the optic disc and specific patterns of visual field defects. And why does glaucoma occur? If you look at this diagram, you can see that this is the ciliary body from where the aqueous is produced. So this aqueous exits the eye through two pathways. One pathway is the trabecular pathway, which is shown in the red here, into the trabecular meshwork in the anterior chamber, and the other pathway is through the uveoscleral outflow, which takes the aqueous out of the eye. So it is imbalance between the inflow of aqueous and the outflow of aqueous, which leads to glaucoma. And if you look at this, it is very easy to understand how can we control glaucoma. Either we can decrease the production of the aqueous, or we can increase the exit of the aqueous through two pathways, that is exit of aqueous either through trabecular meshwork or exit of aqueous through the uveoscleral pathway. So these two can be used to remedy the situation. We'll come to the drugs that have effect on these pathways. Glaucoma can be congenital, and we have baby coming with the watering, enlarged cornea, and photophobia. And it could be a congenital glaucoma, or it could be in the early days, in the early weeks or months of the life. It can be acquired. And again, it can be open and closed angle. So this classification is important because all closed angle glaucoma need a procedure which is called iridotomy, which is done with a laser. And of course, it can be primary, and secondary glaucomas are because of some identifiable disorder. For example, it could be inflammation, it could be steroid-induced, it could be neovascular, so many types of there. I won't go into details of this. Remember one thing, in the Europeans and African population, the glaucomas are mainly primary open-angle glaucomas. But 91% cases of blindness in China are due to angle closure. So one end of continuum is the cases European and African. On the other end, we have China. But in our population, we have the almost equal number of open angle and angle closure cases in our population. So all, as I told you, all angle closure cases would need iridotomy. So this is the prevalence in the very important study, Aravind Comprehensive Eye Survey. Its prevalence is 1.7% for open angle glaucoma and 0.5% for primary angle closure glaucoma. Eye diagnosis delayed there are no symptoms here except in angle-clear glaucoma, where patient may come with the photophobia, or he may have even seeing the colored halos around light at night. Angle-clear thus can have some symptoms, but generally the patient, it's a symptomless disease. Early visual fields can be detected when 40 to 50% of optic fibers are already damaged. So that means early damage won't have any symptoms in open-angle glaucoma, except angle-clear, as I told already. And glaucoma damage cannot be reversed, but progression can be retarded. If you look at this diagram by Dr. Weinreich, you can see that initially the basic what is happening is apoptosis. Apoptosis is the death of the programmed cell death. So apoptosis starts in the ganglion cells. There's a death of RGC ganglion cells, but the disease remains asymptomatic in the initial stage, and it's asymptomatic. But then comes functional change in the disease occurs at a very late stage that can be picked up as our visual fields with the ocular fluorescence tomography and all investigative tools. That means we have to detect the glaucoma somewhere earlier than these changes appear, and these changes earlier can be picked up on optic disc examination. And the early stage, like we talk about the glaucoma damage in the mean deviation, like in the early stage, there's a driving difficulties. Patient says can have a problem in driving, but then when the damage is advanced, patient has loss of the peripheral fields, and he bumps into objects. He has accidents. He bumps into the furniture, stool, or other objects. So you may come up with a fall. In advanced glaucoma, center is affected and there are reading difficulties. And of course, in severe glaucoma, the orientation problems are there, and patient has failing vision at that point of time. So the goal of glaucoma treatment is to maintain the patient's visual function and related quality of life at sustainable cost. Quality of life is very important. Glaucoma treatment leads to side effects like hyperemia and others. So you have to maintain the quality of life in these cases. So what are the goals of glaucoma treatment is to keep the vision sustainable throughout the patient's lifetime. If somebody is 30 years old and is diagnosed with glaucoma, we have to sustain his vision till his may survive to be 70 or 80. And we have to sustain the vision till that time. Whereas in older patients, 80 years old, if glaucoma is diagnosed, you may go low and slow in those cases. In either cases, we have to prevent the functional loss and blindness, which is the end result of untreated glaucoma. We have to take the history of the patients. Important is to bronchial asthma, heart blocks, because beta blockers are one of the mainstays of treatment. So there are a lot of contraindication to beta blockers. And then we have to evaluate by using the various tools that are disposable. Clinical tools are tonometry and diurnal variation. Diurnal variation is very important. You take split diurnals. Like one day you call the patient at 9 o'clock in the morning, one day call him in the afternoon, one day call in the evening, and take a and note the diurnal variation, the intraocular pressure. And of course, then gonioscopic disc examination and various other investigative tools are there. But most important, two clinical skills that ophthalmologists need to learn is gonioscopy and the disc examination. If any ophthalmologist is able to do good clinical disc examination and do good gonioscopy, he may be able to pick up the glaucoma. IOP may be normal in normal tension glaucoma, but you will still have changes in the visual fields and this change there. These are most important. These are various devices which are used to take intraocular pressure. One we use mostly is a Goldman applanation tonometry, which is the gold standard for measuring the intraocular pressure. This should be used actually. So other devices are second to this only. So this is the ideal thing to have. And of course, we have this, Sensimed triggerfish is one thing. It's a contact lens which takes the reading over the 24-hour period. So it is applied to the cornea, and it takes a reading by measuring the changes in the corneal status. And this triggerfish can give you 24-hour reading what is happening, because we ideally, as treating doctors or ophthalmologists, we want the IOP should remain at the same level over the 24-hour period time. It's not that it should be high in the morning and low in the evening kind of thing. most important thing to learn this skill is to clinical examination of optic nerve head. Slit limb microscopy is done with 60, 78 or 90D lens. It gives you a stereo view of the disc and gives you magnified view. And this can be measured also. So look for focal thinning and in notch in the optic cup, acquired optic disc split, generalized enlargement of the optic cup, vertical enlargement, disc hemorrhages, RNFL thinning or wedge defect, which you can see in the second picture from above. You can see a disc hemorrhage, you can see a wedge defect, which is seen in the brighter area along the arcuate pathway. And look at the cup asymmetry in the two eyes. More than 0.2 cup asymmetry is significant if it is there in two eyes. And also look at the peripapillary atrophy. Stereo images are very good to document the case and to follow up the case. If you have stereo images of the patient, and you can repeat, the repeatability is there and you can find the subtle changes and pick them out. Optic disc hemorrhages are best seen in the red-free photograph. You can see them. You may miss them on cursory examination, but they picked up very well on with the red-free photography. And sometimes you may actually, these hemorrhages actually indicate worsening of the glaucoma. And you may have to decrease the dioptric further. There's something called an isn't rule, which is very important. Isn't rule says that inferior rim is rim, which is thicker than nasal rim, which is in turn thicker than the temporal rim. And you look at these two discs, on cursory examination, they may look to be same, but if you look at these discs, you can see that the one is non-glaucomatous disc, other one is glaucomatous disc. And anterior thinning of the neuroretinal rim, which are thinner than the actually nasal rim also, and almost as thick as temporal. So isn't rule is disturbed, and this is a glaucomatous disc. They may look same. Large disc could have a large cup, and which may erroneously be interpreted as glaucomatous disc. Then examine the region of parapapillary atrophy. You can see there's atrophy around the disc. So then after looking at the alpha and beta zone peripapillary atrophy and disc examination, you can find out, you can assess that whether disc is normal or glaucomatous. Then gonioscopy lens is used to look at the angle of anterior chamber. Why do you want to look at the anterior chamber? You want to classify the glaucoma as open angle or closed angle. And I told you as the start that closed angle glaucomas would need iridotomy as one of the measures in the treatment pathway. This is what you see in the gonioscopy. This is open angle showing all the structures that are visible. If angle is closed, you may not be able to see the ciliary body or iris or Schlemm's canal. Some of these structures may not be seen. And of course, gonioscopy is must. And this skill is very important to learn for every ophthalmologist. And then comes the visual field. Humphrey's visual field printout you can see here. And you can see, if I can just you can see the pattern deviation. You can see some black areas. I won't go into details of interpretation of this field test, but these field tests test you whether any damage is there or not. And of course, you can find out if progression is there. So if you do sequential field test over a few months or period of time, you can see that there is a decrease in the field effect and the over a binary part. So this shows there's a worsening of glaucoma. So depending on the field effects, in real fields, there's a one term called as mean deviation, which is on the left side of the printout. Mean deviation and the visual field effects can be used to quantify the glaucoma. For example, if mean deviation is less than 6, it's a mild glaucoma. If mean deviation is 6 to 12, minus 6 to 12, it is a moderate glaucoma. And if it is minus 12 and more, then it is an advanced glaucoma. And then, of course, the central is involved in advanced glaucoma, and vision is involved. Vision is impacted in these cases. And then you have OCT, which is retinal nerve fiber layer analysis. So this is one investigation which tells you about the nerve fiber layer around the optic disc. We all know that glaucomatous damage to the nerve fibers in the spirotemporal and infratemporal region of the optic disc. So once these are impacted, you would find these changes in the OCT. So you can do sequential OCT again to follow up the patient. If you see the last 4 round pictures, they will show you the red areas. So red areas indicate there is a thinning of retinal fiber layer in those quadrants. So there's an hourglass Glaucoma map is there, one RNFL quadrant map is there at the bottom. So the red areas indicate there's a thinning of retinal fiber layer. And now the next vista that we are exploring is the OCT angiography in cases of glaucoma. OCT angiography is a non-invasive tool, and you can see the peripupillary capillary network and the vascular network in the macular region. So in these cases, at the bottom, you can see in the picture and compare the upper one, you can see there's a decrease in the vessels in the around the disc also and around the macular area also. So these are the new investigations that are being used to see the defects in the glaucoma patients. So one case, which was 24-year female, she came with the CD ratio, vertical CD ratio 0.6 and 0.8, essentially asymmetrical glaucoma with IOP of 24 and 36 and right and left eye. And this was their OCT. On OCT, you can see there's a advanced field effects in the right eye, and there is the advanced field effects in the left eye, whereas right eye has, just superior field effects. And if you look at this, then you can see that this was the visual fields. So right eye has mean deviation of minus 0.54, as I told you, less than minus 6 is early glaucoma. So she has early glaucoma in the right eye and advanced glaucoma in the left eye. So for both these eyes, the treatment would be different. That means the amount of IOP lowering required would be different. So that means if it is a mild glaucoma, you may keep IOP around 18 or so. If it is a moderate glaucoma, the IOP has to be kept somewhere around 15. But if advanced glaucoma is there, you may lower the IOP to 12 or so in cases. So you can say probably if I'm treating this case, I would like to treat the right eye with some bring the IOP down to 18. And the left eye would like to bring the IOP down to somewhere around 12 or teens. And the other thing I just want to share is a young girl, prostaglandins should never be given in one eye. Because in one eye, if you give prostaglandin, there will be hyperemia, there will be change in lashes, and there are certain side effects of prostaglandins. So they will lead to changes. So in these cases, always give prostaglandin bilateral if you want to give them. The next vista in the investigative techniques of this glaucoma is the ganglion cell layer analysis. Now, we all know that ganglion cells are affected. There's a damage of ganglion cells and apoptosis is there. And you can measure actually the thickness of ganglion cells. There's a one case, 71-year-old male had bilateral open angle glaucoma with family history of glaucoma. And in 2015, the patient has some changes in the one eye, right eye and left eye field, as you can see absolutely normal. And you can see in the 2018, there was some nasal step and some changes in the arcuate area in the visual field. And if you look at the ganglion cell analysis, look at the upper diagram, you can see there's a right and left eye. You can see right eye, you can see there's some horizontal raphe is there if you look at it closely. So this is also called as temporal raphe. Temporal raphe is the temporal side, which indicates, these changes in the, nasal step. You have temporal raphe in the macular analysis of the RGCs. And you can see there are changes in this. The important thing about this is that if patient is having a disc like myopic disc or tilted disc, the OCT or RNF nerve fiber layer analysis may not be good, but you can pick up those changes in this OCT macular ganglion cell analysis. So this is in the 2020, you can see the further change in the ganglion analysis, and you can see the further changes are present and advanced changes are present. So what is the aim of the glaucoma treatment? Basically, the aim is to stop the glaucoma progression and to preserve the visual function and maintain quality of life at sustainable cost and affordable cost with acceptable side effects. All anti-glaucoma drugs, they have side effects, so we have to take care of them. You have to give rational combination of drugs or single drug. So something concept which is very important in glaucoma that is called as target IOP. Target is, for example, if you have blood pressure, you say we want to bring the blood pressure down to maybe 130 by 80. Some old patient may have 160 by 90 would be acceptable, maybe 150 or 80 may be acceptable. Similarly, for each patient, we individualize the target IOP, that how much lowering is required. For example, if there is a glaucoma damage, which is early, let's say the early effect in the visual field is there, you may have target of around 18 or so. And if patient is having life expectancy is low, you may have higher target IOP. You may keep IOP around 18. But similarly, untreated IOP, if the patient comes to you with an IOP of, let's say, 24, you will keep it around 18, 17, 16. Or if patient comes to you with the IOP of 18 and the damage, then you bring it down to 12%. So this falls into normal tension glaucoma. So the rule of thumb is, which studies have told us, is if there is an ocular hypertension, 30% lowering of IOP is required. If at all, it has to be treated. If patient has normal tension glaucoma, then IOP has to be lowered by 30%. I'm sorry about this, but ocular hypertension, only 20% reduction is desirable. And in normal tension glaucoma, 30% IOP lowering is desirable. So these are various drugs that we have in our armamentarium. We have lucky in these century, in the first 2 centuries and the last decade of last century, we had a lot of drugs coming in. We had, prostaglandins, brinzolamide topically instilled, brimonidine, and brinzolamide topically instilled, and of course, netarsodil. So these are all new drugs that we have in our armamentarium. With the result now, more and more cases are being treated with the medical therapy alone. Whereas, almost 90% or more cases can be treated and tackled with the drug therapy only. Some drugs have their side effects, So these are the various therapeutic choices. To look at these, the prostaglandins are the most potent IOP lowering drugs. They lower the IOP to the tune of more than 30%. Whereas it's a beta blocker, alphanist, harmonic anhydrous, osmotics, IOP 5% with either of these drugs given alone. But then we have combinations. So most of the combinations are with timolol. Only one combination is with carbonic anhydrous, and after that is brimonidine and brinzolamide. So each combination has timolol. And mind you, the timolol, I told you, cannot be given to the patient with bronchial asthma, with the obstructive airway disease, and patients having advanced cardiac CHF, and obstructive airway disease. And so there's so many contraindications and some relative. So then you can bank on brimonidine and brinzolamide also. And there's one term called as maximum medical therapy, or one is maximum tolerated medical therapy. So ideally, you shouldn't be giving more than 2 bottles to a patient. So if you want to give maximum therapy, it could be a bottle of, let's say, prostaglandin plus timolol, 2 drugs in 1 bottle, and plus brimonidine plus brinzolamide in second bottle. So you can have 2 bottles in a day. If you give more than 2 bottles in a day to instill to the patient is likely to have compliance is suffered, and patient may not be adhered to the therapy. So adherence and compliance requires good regime of IOP eye drop installation. So these are the factors which you take into account when you start the treatment. Look at the efficacy of the drug. Start with the most efficacious drug if there's no contraindication. For example, prostaglandins are the most efficacious drug. You start with the travoprost, bimatoprost, or lecnoprost. And the safety. The drug which is safer in the long term should be given. For the beta blockers, you should look at the side effects, and it shouldn't be any contraindication. Look at the mechanism of action. I told you, you can reduce the IOP by 3 mechanisms. Either you decrease the production of aqueous, or increase the trabecular outflow, or increase the uvascular outflow. So combine a drug decreases the outflow, which increases the outflow. So that is a rational combination of drug. Then some questions are there to treat or not to treat. Somebody 85 years old with life expectancy of 5 to 10 years, you may not choose to treat if the defect is early. And look at the quality of life. Fix the treatment goals, what you want, 18, 15 or 12 mm of IOP at the end of the treatment as a treatment goal. And maximum medical therapy I have already talked about, and how many drugs. Look at the cost. Cost is one factor which is very important in our society. And then you look at generic drugs versus innovator drugs. So you have to take a call on this, risk versus benefit ratio. Prostaglandin has these adverse effects. It leads to change in the color of iris, increase in the length of the cilia. The cilia become thick and they increase in length. The skin hyperpigmentation is there. It can lead to increased iris pigmentation. It can lead to recurrence of herpes simplex and prostaglandin associated orbitopathy can be there with these. Beta blockers we have already discussed, and alpha-2 agonist can lead to conjunctival hyperemia, follicular conjunctivitis, dry mouth. The important thing is it is not to be used in children less than 7 years of age, 8 years of age, as it crosses the blood-brain ocular barrier. Topically instilled are dorzolamide and benzolamide. Dorzolamide leads to the bitter taste in the mouth. Benzolamide leads to the deposits in the eyelashes and the lids. Whitish deposits are there, so you can choose whichever patient prefers. Tarsodil is new kid on the block. This is a drug recently introduced. It relaxes the trabecular meshwork and increases the trabecular outflow. It leads to conjunctival hyperemia, cornea verticillata, conjunctival hemorrhages, blurring of BN, lacrimation, erythema of lids. So a lot of people drop out of this drug, but this is another drug in our armamentarium to tackle the glaucoma. This is a drug which is not available in India, in which latanoprost and pinot is added to this. And it's a little more effective than the latanoprost, which is a prostaglandin analog. So how do we start the treatment? We start with a monotherapy, start with single drug, or you can start with the prostaglandin, brimonidine, timolol, or any drug. If it is not being efficacious, then replace the therapy. For example, replacement monotherapy means if patient is on prostaglandin, try timolol. If it is not being effective, try another drug. In fact, you can try to substitute one prostaglandin with another prostaglandin. For example, if the patient is using bimatoprost, you can start with latanoprost or even travoprost. You can try that switch. And if none of these work, then try a combination treatment. I told you combine 1 or 2 drugs, 3 drugs out, and maximum medical you can give is 4 drugs in 2 bottles. That is prostaglandin plus timolol in 1 bottle. And of course, dorzolamide and benzolamide in another bottle. That's a maximum therapy you can give. So what happens if all this fails? So then the patient will need surgery at the end of the day. Now, none of these is working. So if IOP is not controlled with the drugs, patient is not complying with the treatment because side effects, or side effects are there to the eye drops, or patient disease progression is there despite medical management. In our milieu, the patient may say, I can't afford the drugs, or patient may say, I can't come for the follow-ups. So in these cases, you can think of doing surgery in these cases. And we have, these various surgical options available with us. We have open eye trabeculectomy is there, which has stood the test of time, in which we create a fistula between the anterior chamber and the subtenon space. And of course, you can combine trabeculectomy with mitomycin C. Then we have, glaucoma drainage devices, which are in vogue now. So you have shunts like express or mini shunt. You can have different kind of tubes. These tubes can, again, drain the aqueous into the subtenon space. And they have valves, again, the same. So idea is to drain the aqueous through the trabecular meshwork or through the trabecular meshwork. For example, as it makes like eye stand, trabeculotomitis. Here you create a pathway between the anterior chamber and the trabecular meshwork and the Schlemm's canal. So lasers, like one of the uses of laser is like iridotomy, I had told you, should be done in all angle fluid glaucoma cases. It is a therapeutic modality. It may not lower IOP, but it can prevent the increased IOP or the chances of IOP having episodes of increased IOP in these cases. And SLT and ELT are other modalities. SLT and ELT, one is selective laser trabeculoplasty, or other is argon laser trabeculoplasty. So these lasers, as shown in the lowermost picture, they target the trabecular meshwork. They produce changes in trabecular meshwork, which increase the trabecular outflow. They are especially useful in pregnant patients who cannot take any medication, or they can be additive or adjunct to other medical therapy, or they can be primary therapy also. And of course, another modality in lasers, which is nowadays available, is CPC diode laser. CPC is cyclophotocoagulation diode laser, but now we have a micropulse diode laser. So micropulse diode laser is applied transconjunctivally. It is applied through conjunctiva on the ciliary body. It basically destroys the ciliary body epithelium and decreases the production of aqueous. This is called transclear CPC diode application. And micropulse means that a laser is given in small pulses over the ciliary body through conjunctiva and sclera. And this can be used in patients who don't want surgery and need surgery. The patients having neovascular glaucoma, patient having glaucomas which are, for example, for penetrating keratoplasty or following keratoplasty, or different kind of glaucomas can be used, can be ameliorated with this technique. But the only thing is it may lead to hypotony of the globe. That is one thing. And then surgical treatment, we are talking about trabeculectomy, and then we have glaucoma drainage devices which are implanted in the subtenon space between the muscles. And this is a tube. This tube drains the aqueous through this tube. The aqueous is drained into the implant. Then we have these implants which are inserted in the trabecular meshwork. Now we are talking about artificial intelligence. And these photographs can be seen, they can be analyzed by deep learning algorithm, Pegasus and Google Net Deep Learning Network. In future, we are thinking that just send him a picture of retina and maybe it can give you better results than your human error can be avoided. And then artificial glaucoma retinal image analysis there, which can look at the cup size, this size, and configuration of the cup. It can analyze that. To conclude, opportunistic screening and cleaning and CAMS is important for early diagnosis. That means once the patient comes to your clinic, do the IOP in all cases. So you can find so many cases. And regular checkup if you have family history or other risk factors are there. If you are diagnosed with glaucoma, regular treatment and follow-up is required. And step up the treatment if progression is there. If patient is progressing despite treatment, go for a higher, more number of medications or surgical options. Permanent visual impairment can be prevented. So you have to really treat it aggressively, and follow-up is required, and the follow-up fields and checkup is required. And I think the message should be given loud and clear to all the groups wherever you are, that after 40 or with family history, you need to get a checkup done. Thank you very much.
Oh, thank you, Dr. Gursatinder, for a wonderful presentation. And I'm sure this will help general ophthalmologists as well as general physicians. And you have given very apt messages, the take-home messages also. And it is really surprising that 76 million suffer from glaucoma worldwide. And almost 12%, 10 to 12% of blindness in India is because of the glaucoma. And equal number of angle closure glaucoma, and the primary open-angle glaucoma, they are present in India.
Yes.
And the prevalence of open-angle glaucoma is as high as 1.5%, which is quite a lot. And you also told about the ISNNT rule, and that is very good. So, and it was very, the pictures were really good. So I liked about your presentation was the pictures were self-explanatory, almost shown the how it progresses, the glaucoma progresses is really good. And it is also good that 90% of the cases, they can be treated on medicines. And we don't,
Yes.
you told about all the modalities of the treatment, but it is good that 90% of the people suffering from glaucoma can be treated by medicines. You also told about, I wanted to ask you about the micropulse transscleral cyclodiode lasers, and you have told about it in briefly, but I think we can have a whole webinar on that modality of treatment also. So thanks a lot. Dr. Gursatinder will be sharing some of the questions which the participants they pose on your email ID or with the DocPlexus, and will be shared with you. So you can answer them whenever you feel comfortable, and we'll share with the participants. So thanks a lot.
I'll do that. Sure, I'll do that.
Well, thank you, Dr. Gursatinder. Thank you.
Thank you, Dr. Kesh, for involving me in this very important endeavor. I think I'm very lucky to be in a field where not many people are working,
Yeah.
It's always a privilege.
That is
to be
good.
part of
Good
it.
thing about it.
Yeah.
Because the glaucoma is not very rewarding field in the sense that the treatment and the results are not immediate, as in the phaco surgery for the cataract. So, but you have dared to work in this field, and that is commendable. Thanks a lot.
Right. Thank you. Thank you, Dr. Kesh. Thanks a lot. Thanks.
Thank you.
Thank you so much, Dr. Singh, for that very detailed and insightful and informative presentation. It's been a pleasure listening to you and about understanding the ways in which glaucoma can be detected and prevented early. Thank you so much, Dr. Rakesh Gupta, for chairing the session. Always a pleasure to interact with you, sir. To all our audience members, thank you so much for your participation in today's session. If you have any questions for Dr. Singh, you may please drop them in the chat box below, and we will get back to you with the responses as soon as possible. Thank you so much for being a part of today's session. We will be back with another clinically riveting session in the evening at 6 p.m. See you then. Until then, please take care. Thank you so much.